figuring out what are those multiple pathways to psychosis and what's different about the refractory patients. What kind of illness is that? Now, in contrast to those genetic disorders I just showed you, which are known by another name, these are the actual risk genes that have been found in true schizophrenia around the world. Researchers are finding those almost every day now with the molecular genetic techniques, and it's very exciting because we're discovering numerous risk genes. Not a single one of those will make you schizophrenic. But if you have 3 or 4 or 5 coming from both sides of the family, a patient that one of the people in the family becomes schizophrenic. The other members may have 1 or 2 of those genes, which is why family members of patients with schizophrenia may show some, what we call the spectrum symptoms. They're not sick, they're not psychotic, but they have some axis 1 or axis 2 disorders, and they have cognitive deficits. There are numerous studies showing that the parents and the siblings of a person with schizophrenia actually have impaired cognition. And some of them have negative symptoms too. They don't show a lot of emotion, they're socially awkward, etc. But we don't recognize, they're not sick, they don't come for treatment, but they're carrying 1 or 2 or 3 of those genes, whereas the patient has carried many more due to the confluence of genetics from both sides. Now, here's another point that I want to make. The secondary negative symptoms can actually be due to things like psychosis itself. Be careful about labeling somebody a negative symptom as a primary negative symptom, because when a patient is in the acute psychotic state, they withdraw and they don't talk much, and they speak very little, and that looks like negative symptoms. These get better when you treat the psychosis, so they are reversible negative symptoms. And then you see the real negative symptoms at that point. The avolition, anhedonia, and the true alogia and the apathy emerge at that point. Too much dopamine blockade, unfortunately, the treatment that we give, excessive dosing, which was very popular in the old days, can cause negative symptoms because you're reducing dopamine in the frontal area. Remember, negative symptoms are a frontal lobe syndrome, basically. It's if you damage somebody's frontal lobe with a car accident or a bullet, you're going to get negative symptoms, just like a schizophrenic patient. And that's why we attribute the true negative symptom to a frontal lobe pathology in schizophrenia. But you can induce that pathology by depriving the frontal lobe of dopamine. Same thing with cognition, by the way. People with depression, schizophrenia patients with a depressive episode can look like they have a lot of negative symptoms, but these are secondary negative symptoms. You treat the depression and the negative symptoms go away. And then obstructive sleep apnea can actually cause the daytime fatigue and sleepiness, and the patient looks like they have negative symptoms, but they're not. It's OSA. And secondary depression and schizophrenia is also due to excessive dopamine blockade, by the way, or PTSD. Psychotic symptom and a psychotic episode can actually induce PTSD in the sufferer. I mean, we don't actually diagnose it very often, but careful studies show that many schizophrenia patients develop a post-traumatic stress disorder from this incredible event that shatters their world and makes everything look so different and feel so different, and people are going to harm them, and they can't tell who they are anymore. There's a destruction of the sense of self. It can be very traumatic. And then iatrogenic depression, like any number of drugs that we give our patients. Same thing with cognitive deficits. Be careful, separate the primary from the secondary. Again, too much antipsychotic dose, high dopamine blockade can do that for the frontal lobe. Anticholinergic medication, that's another thing that can cause secondary negative symptoms. That's why I told you yesterday I hate using anticholinergics if I can. Weight gain is now being shown to induce severe memory deficit. The higher your BMI, the worse your memory. And that's why it's another benefit for losing weight, not just to prolong your life and avoid heart attacks, but it improves your cognition. And our patients are all overweight, obese because of the medications or because of their lifestyle, and some of their memory deficits could be actually reversed by treating their weight and also by treating their high blood pressure. Turns out hypertension can also adversely affect memory. And again, obstructive sleep apnea can really deprive the brain from oxygen at dangerously low levels, and that can, of course, cause ischemia. Now, clozapine is the only evidence-based treatment for refractory. Nothing else is approved at this time. But what I'm going to show you now are numerous studies that were done. In case clozapine doesn't work or work only partially, what else can we do to help the patients? Now remember, adequate clozapine trial in the clinical trials was 6 weeks, and the patients improved dramatically overall compared to chlorpromazine or compared to one of the atypicals. But it turns out the longer the patient stays on clozapine, if you go 3 months instead of 6 weeks, and you capture more responders, and if you go to 6 months, even more patients respond, and 1 year even more. So it looks like there are early responders and delayed responders. So don't give up on clozapine too soon, because not only is the dose important, but duration. I'm always delighted when I see my patient gradually becoming normal after several months sticking with it. Now, why do